Thanks, Mr. Chairman, for giving me this opportunity to present our work. The title of my presentation is about laparoscopic common bile duct exploration versus intraoperative sphincterotomy for management of common bile duct stones. 4 decades ago, the only possible management for common bile duct stones was open common bile duct exploration. But 2 revolutions appeared and paved the way for introduction of minimally invasive techniques in the field of biliary surgery. These are the advent of ERCP with endoscopic sphincterotomy, and the second is laparoscopic cholecystectomy. Nowadays, we have many options for management of patients having gallstones with concomitant common bile duct stones. It could be an open common bile duct exploration or minimally invasive approach, either in a staged manner in the form of preoperative ERCP followed later on by laparoscopic cholecystectomy, or laparoscopic cholecystectomy followed later on by postoperative ERCP, or a single-stage approach in the form of one of 2, either common bile duct exploration by laparoscopy or intraoperative ERCP. It goes without saying that the minimally invasive approach has many well-known benefits, and also the published studies show that the single stage is far advantageous than the 2-stage approach due to 1 anesthesia, 1 hospital admission. You can cure the 2 pathologies at the same setting. This means that shorter hospital stay, lower cost, and moreover, equal success rate for the 2 approaches. The aim of our work is to find out what is the best single-incision minimally invasive management for gallstones and concomitant common bile duct stones. Is it common bile duct exploration or intraoperative ERCP? Our study spanned a period of about 3.5 years. It was conducted in Mansoura Gastroenterology Surgical Center in Egypt, and we included patients having gallstones with high probability of common bile duct stones as evidenced clinically by blood tests, abdominal ultrasound. And all enrolled patients had MRCP to be sure that there are common bile duct stones, or by ERCP evidence from previous endoscopic management. We excluded patients having cholangitis, biliary pancreatitis, suspected common bile duct malignancies, or contraindications to ERCP or laparoscopy. All eligible patients were randomized after performing intraoperative cholangiogram in order also to be dead sure that there are stones in the common bile duct. We used the sealed envelope technique, which was drawn and opened by a nurse not otherwise engaged in the study, and we divided our patients into 2 groups, common bile duct exploration and the intraoperative ERCP. Fortunately enough, in our center, the surgeons are performing ERCP. So the surgeon who did laparoscopic cholecystectomy is the same surgeon who did intraoperative ERCP. The technique of laparoscopic common bile duct exploration, as usual, it could be either through the cystic duct or through direct claudicotomy based on the diameter of the common bile duct, the anatomy of the cystic duct, and other variables well known to all of us. Unfortunately, we had no flexible claudicoscope after we broke in 2 of them, so we depended on fluoroscopic guidance for removal of common bile duct stones. Regarding the intraoperative ERCP, we did not use the combined laparoendoscopic technique, or what's called the rendezvous technique. We did intraoperative ERCP after completion of laparoscopic cholecystectomy and the closure of the ports, and we turned the patient to the left lateral position. We felt this is more successful and more safe than the usual rendezvous technique. Our primary outcome was the success rate for clearance of the common bile duct with other secondary endpoints. We had in our study 321 patients who have common bile duct stones, 24 were non-eligible, and 45 had no stones at MRCP. Also, 27 patients had no stones at intraoperative cholangiogram, so we analyzed 226 patients who were divided into laparoscopic common bile duct exploration group, including 115 patients, intraoperative ERCP group, including 111 patients. This table shows the preoperative data between the 2 groups, and we found no significant difference regarding the demographic data presentation or the MRCP findings preoperatively. This is the outcome for our group, which is laparoscopic common bile duct exploration, and we found that we had an incidence of failure for 6 patients had failed, and it succeeded in 106 patients. The patients who had successful laparoscopic common bile duct exploration had transcystic or direct claudicotomy approach, and this shows the technique of decompression of bile ducts after surgery. We can see in this table the causes of failure and subsequent management for failed cases, which were 6 patients. This is the operative time, which was about 62 minutes. The hospital stay 2.4, we had no mortality, and we had post-surgical complications rate of 7.5%. We had an incidence of retained stones, which is 3.8%, and they were managed by post-operative ERCP, intraoperative ERCP, or post-conservatively without any intervention in 2 cases. This is the outcome for the intraoperative ERCP group, and we show that the incidence of failure is 3. 3 patients failed out of 107 patients. Because this is the cause of failure, which was failure of endoscopic cannulation in 1 patient and incomplete stone clearance despite successful cannulation in 2 patients, and they were managed by laparoscopic claudicotomy or placement of stent followed by post-operative ERCP later on. The operative time was 74 minutes, hospital stay 3.2 days, post-operative complications or post-surgical complications was about 8%. Most common was bleeding babelotomy and pancreatitis, which was actually mild pancreatitis and treated conservatively without any surgical intervention. When we compare between the 2 groups, we found that the success rate is nearly equal. It is more in the intraoperative ERCP, but the difference is not significant. Also, the surgical time is the same, hospital stay, complications. The only significant difference between the 2 groups was the rate of retained common bile duct stones, which was higher for laparoscopic common bile duct exploration. It was 3.8%, and we had no retained stones in the intraoperative cholangiogram. Definitely, we had limitations in our study. The first and most important limitation is the absence of claudoscope, which definitely would increase the rate of success for laparoscopic common bile duct exploration. And the second is the short-term follow-up. We followed up our patients only for 30 days. But based on our results, we conclude that there is no difference between both options in terms of the success rate, the surgical time, length of hospital stay, the complication rate. And the only significant difference was the incidence of retained stones. And so both options are valid for treatment of patients having gallstones with concomitant common bile duct stones. However, intraoperative ERCP would be more preferable alternative to laparoscopic common bile duct exploration, provided that the facilities are readily available and expert endoscopists are available. Thank you very much.
Thank you for that interesting paper. Dr. Brunt.
Michael Brunt, St. Louis. I'd like to congratulate you on this study, a beautifully presented prospective randomized trial, and for taking us back a bit to our roots in biliary surgery. My question for you is, in the United States, intraoperative ERC is very uncommonly performed or available. Do you have any information about the cost differences between your 2 groups? Because in our algorithm, the ERCP is usually done post-operatively. It may require an extra day in the hospital, and so there could be a significant cost difference. My second question relates to, you had 5 cases of bile leaks in the laparoscopic common bile duct exploration group. Were those in the transcystic group or the direct choledochotomy? Can you give us a little more information about that and how you might prevent those from occurring? Thank you again for a wonderful paper.
Thank you. First of all, you raise an important issue, which is the cost. Cost saving is important, but we did not actually take this point into consideration till now. We are running a larger study and for more patients and taking the point of cost in our consideration. And I think the results will be ready within a few months. This is regarding the first question. I think intraoperative ERCP would be more costly, but let us wait to see the results of our study. Regarding the second question, bile leak occurred in 2 patients having transcystic common bile duct exploration. One of them had small stone at the lower end, common bile duct retained stone, and it was removed by ERCP, post-operative ERCP, and bile leak stopped. Definitely, we had to place a percutaneous drain. 2 patients had primary closure of the common bile duct after direct clodocotomy. 1 patient we did not need further than conservative treatment, and the other patients had tube drainage, and we waited till it stopped leakage. But 1 patient had a leak around the T-tube. This patient was elderly and was not fit for laparoscopy, so we had a laparotomy for repositioning of the T-tube and the closure of the site of the leak. Thank you.
Question from Dr. Marks.
Jeff Marks, Cleveland. I want to echo Dr. Brunt. That was a fantastic study. One comment, I'm sure once you get your flexible choledocoscope, you'll be able to get rid of your retained common duct stones with your explorations. I have one question for you. With the 3% rate of unsuccessful ERCP and the excess time, are you guys looking to do these supine? We routinely will do our ERCPs, with the patients in the position for the lap chole. It may save a little time. And if you are unsuccessful cannulating, you can always do your rendezvous and make that 0% in terms of your inability to do the ERCPs.
Yes. In general, we have 2 techniques, as you said, for intraoperative ERCP. The first is the combined laparoscopic technique, in which we pass a guide wire through the cystic duct, and the endoscopist retrieve this guide wire and thread the papillotome along it for cannulation. But we tried this early in our study. We tried this technique in our study. Actually, we had an instance of failure due to the spiral valves. Sometimes we could not introduce the guide wire. 1 patient had a complete torn cystic duct during introduction and manipulations for introduction of the guide wire. Also, we found that performing ERCP and papillotomy with the patient in the supine position is more difficult, somewhat more difficult, needs certain modifications in the position of the endoscopist to perform this job. And also, laparoscopic cholecystectomy was definitely somewhat difficult due to bowel distension after removal of the stone, and you enter again in the abdomen to perform complete laparoscopic cholecystectomy difficult. So we depended mainly on immediate post-operative ERCP after finishing laparoscopic cholecystectomy. Finish laparoscopic cholecystectomy and close the ports. Then we turn the patient in the left lateral position, and we perform the conventional standard technique for ERCP. And we found it nice. If it fails, we could again introduce the laparoscope and do laparoscopic common duct exploration, or for post-operative ERCP, or sometimes for open common duct exploration.
Thank you.
Thanks.
Thank you very much. Thank you very much.